I think I recognize a lot of names, but my name is Emilia Andersson, in case we haven't met. I work for Roche in the medical and government affairs team, and I am a pathologist as well. And me and my colleague Anne, we are very proud sponsors of these modules of proficiency tests. So this time, I hope you had the opportunity to actually score cases on ALK and ROS1. And Corrado and Simona, they will walk us through the scores, so how we did, as well as explaining us the challenges, and we will review the cases together. As always, please feel free to enter questions in the chat or raise a hand, or if you want to speak up. Otherwise, I will read the questions out loud. And with that, I hand it over to Corrado and Simona.
That's perfect. Thank you. Thank you, Emilia. Thank you all for coming back to this circulation. I was looking at these cases and I kind of had the feeling it's getting a bit boring, isn't it? You know, they're all either positive or negative, and yeah, but that's okay. I do think,
and I think it's more interesting is going to be at ROS compared to ALK, I think. And
is that because we never find a positive case?
Yes, exactly.
Yeah, that's the problem.
I have the feeling like that.
Yeah.
Even the most beautiful full positive, they're fish negative.
Yeah.
But
okay, so review circulation. So the usual format for those of you who don't remember. So this is the overall response of the circulation in percentages. So 96% of people that participate thought this was a negative case. One of it, 4% thought this should be reflexed to an orthogonal test. And this is a panel. So we're now putting panel diagnosis. So a group of experts, nobody's an expert, but anyway, it doesn't matter. Exactly. A group of people that look at these things more frequently. So they are used to the clinical diagnosis, are telling us that they all think this is negative. So that's cool. So let's see the first case, which is called 72, which I think is this
first.
one.
I think they're all in order.
They're in order. Okay, so so that's the H&E, it's a core biopsy. Mm-hmm. I saw in some of the feedback they were saying perhaps you could give us a cytokeratin. It's kind of a good idea, or not in this case. Mm-hmm. It was for a different case. Okay, so these are our tumor cells. Some of them have got this intracellular bluish material, but quite plentiful cells. Could be melanoma, but never mind. Doesn't matter.
The great mimicker.
We trust is a carcinoma.
Yeah.
How do I do it? Yeah. Thank you very much.
And now
this is the ALK. And remember that we have our on-slide controls, which may or may not be very good. I don't know if anybody checked for these things. Will you give a check? Okay, so that's the appendix, and you should be able to demonstrate the neuronal cells in the wall. Can I tell you something? I don't think this is a particularly good example. This is pigment, it's not real, because often we see small nerve fibers, or maybe you see small nerve fibers.
I think you see them.
Yeah. And you should also see them in the mucosa. I'm not really getting the little axons. In the mucosa. I'm calling them axons. Could be just an artifact. Who knows? We are pathologists anyway. And that's the core biopsy. So first glance, and this is the kind of one of the messages of this thing, is that really most of this is low power pathology. You know? Those of you or of us that do hematopathology know that the positive or negative CD3, CD20, it's all looked at low power. Anyway, this is these are our target cells. There is this funny thing that the interpretation guidance says that even one single cell among all these tumor cells, positive, we call it positive.
Well, but there needs to be a very convincing positive, I would say.
Maybe. My experience has always been there is an all or nothing in ALK positive cases. I'll be interested to hear what Emilia thinks about the one positive tumor cell, and do we treat or not treat? So in this case, there are a few.
I can comment.
Yeah, go ahead.
I think it's not that very often, but sometimes it's not often, but I've seen cases with very isolated ALK positive tumor cells, not one single cells, but a few positive cells. And they definitely they are eligible for treatment. I think they are very easy to miss on fish. And they might also be easy to miss on NGS if you have a lot of other tumor cells around.
Of course, they would be drowned into the non-translocated cases. But Emilia, do you know if these patients with very few positive cells actually do respond?
I don't have data on that. I do have data that ALK IHC positive patients respond. Yes. Compared to ALK fish. So if you're ALK IHC positive and fish negative, they still respond. If you have a fish positive and an ALK IHC negative, a little bit more than half of them respond. So in my view, then IHC is a stronger predictor of response.
Yeah. But Simona, what would you do if you had a case of one tumor cell? Oh, okay, let's say not one, as Emilia says a few, like 5 to 10 tumor cells positive scattered about. What would you tell the oncologist?
Well, now, like you always were saying, you need to describe what you're saying. I don't think you can just call it's positive and that's it. I think you need to give an understanding. It's so much tumor I have these scatter cells that are indeed positive, if you really think that they are positive. And I do think it's that kind of conclusion, ALK positive, please see comment.
Yeah.
And the ball, I think, is in their court in that moment, if they want to treat or not.
Yeah, I think probably you should tell the oncologist. So as Emilia says, if you report positive for ALK, so they can prescribe ALK inhibitors. So that's the first step. But then I would probably encourage them to monitor these patients very closely to make sure that you see a response. Otherwise, you just waste time, no response, and then, tumor progresses.
I also think that you should report them as heterogeneous, just as we do for breast cancers, because there are different clones, and maybe you should manage both. We do have 2 questions. Can I ask them?
Yeah.
So the first one here is, do you think the appendix is an adequate control, or should it not be a positive tumor?
Well, this is the objections of EQA providers. In order to do this, you need to have a positive and a negative tumor. Okay, that's probably true, but we kind of gone a little bit away from this concept. We are thinking that the on-slide control should let you know that the analytical sensitivity of the test is adequate, whatever adequate is. And so I don't think you do need positive or negative control. I mean, in the past, they started to made us put HER2 positive and HER2 negative tumors. And that was also a way of saying, look, the HER2 positive is like this, so you should interpret your case like this, etc. But I think we moved away from it. I think the concept of on-slide control is analytical sensitivity and maybe also specificity, obviously, because you have a lot of cells that shouldn't stay in there. So yes, I think, is appendix adequate? Who knows? Do many people use appendix? Yes, definitely. I also was making a comment about our appendix. This particular section was not brilliant, this particular block, because you need to process it better and make sure it's well fixed. But yes, I think putting it any tissue or any cells that shows you that the assay has worked.
But you need to keep in mind, because if you're using a tumor, then like any other tumor, at some point it might have some heterogeneity. And also if it's excision wise and you're starting doing maybe TMAs or start taking little biopsies from it, again, the pre-analytics. So
and also Simona, you need to think that this is all very well, and actually ALK positive non-small cell lung cancer is not hugely rare, so we can all wrestle up a case and start putting
the lung tumor is quite precious material.
It is precious material, but also some of these tests have incidence of 0.something%. So possibly you don't even have a positive tumor.
Yes, exactly.
You may have a biopsy So you can't, so we need to learn how to use the alternative tissue for on-slide controls, yes, or cell lines. If you
I think it was actually Nordic QC who came up with the idea first to use the appendix for ALK.
Right.
And I agree, it's really for the analytical sensitivity that it's important, so we know the assay performs well. The other question, if we can move to that, is do you confirm each case of ALK positive on IHC with FISH or NGS?
Well, you should answer this.
I think it's definitely not needed, and it's not adding extra information.
But in fact, I would say, be careful, because if you do FISH up front, break apart up front, actually, I think you should confirm a positive FISH with an immunohistochemistry, because if you don't have protein, there is no point in treating anybody. Yeah. Protein is key to these matters.
I agree, and that's what we see in outcome data as well. It's the protein expression that drives response.
Fantastic, great questions. Okay, so we go back to PowerPoint, and we go to the next slides. And again, this one seems to be fairly uncontroversial. Everybody thought it was negative.
Sorry to interrupt, but the previous one, I think, again, someone said indeterminate, or it's a 4%.
Yes.
We did have some positive,
why?
not positive,
I have no idea.
some staining in the, but that's not.
I will show you this is pigment.
Exactly. So we need to identify though the tumor, not to fall into the trap, into the pitfall that those are tumor staining, tumor cells
but
staining.
Maybe there was a bit of tumor staining. I don't know. Or not
I
really.
didn't see, at least now when you quickly.
Okay, so if any of you said indeterminate reflex because of this is clearly probably anthracotic pigment, and there was maybe a bit of hemosiderin in another side, there is something here. And again, okay, this one is an unstructured piece of staining, blob. You should be able to see a negative stain nucleus and a positive stain cytoplasm or membrane. So this one, I think you need to use your histopathology, your skills at histopathology to say, yeah, I do believe this is actually a pertinent staining. I would say this, no.
Okay. I'm happy to
move on. So
we have two more comments.
Yes.
Yep.
Back on the control tissue, because here the comment is that Dr. Bishop noticed that the control tumor was weaker, and he is uncertain he would have been able to detect that on a few neurons in an appendix. Would you comment on that?
Paul, this is, I don't really have a tremendous amount of experience about this. I think when we were playing with the ALK1 clone, which was notoriously very much less sensitive, I think this was a big issue. In my experience in non-small cell lung cancer and in other solid tumors, non-hematological malignancies, the amount of protein expression is really high. So I would be surprised if a demonstration of staining in an appendix, and did I show you that I think you should be able to see the axons as well, so not just the neurons. And I think if you have that, and I wasn't really particularly happy about mucosa, because you should be able to see those fibers in the mucosa as well. If you can demonstrate that in appendix, I think he has worked with sufficient sensitivity. But I have to confess, I don't really have a tremendous amount of experience in this type of sensitivity. Sorry.
We have another proposal here from Dr. Stitzen that maybe a double ALK TTF1 staining would be useful. Would you comment on that?
In some cases, I agree. There are some cases that are very tricky, but usually not really. It could be a stain that you combine. There is an issue about doing double multiplex, and the issue is that inevitably in multiplex the sensitivity of the original ALK will be different, so you will need to do an enormous amount of work to show that it's the same sensitivity as the original companion diagnostic, which I don't even know how you would do it. It's going to be really expensive. But I think this is something you could do in parallel. So have an ALK, normal ALK, and then have a dual stain. Why not?
I think this would be more useful, especially on cytology. I think.
Cytology, yeah. I mean, I'm guessing is because we don't want to confuse macrophages with the
Exactly.
usual story. Yeah,
Yeah.
I agree. Yeah.
Okay.
Okay, we move on to number 2. Is this number 2?
No, this is still 1. I think this is 1. Yeah. Yeah.
Yeah,
So
number 2
98.
should be also easy. Let's hope
I
which
think that
one is
one is,
this
yeah,
one is
that
actually.
one.
Okay, another core biopsy looks like chest. It doesn't want to focus, or it's not scanned very well. I hope.
No,
it's
I
just
think it didn't
okay.
focus.
Okay, so that's the carcinoma infiltrating. There is quite a lot.
Is it necrosis there or just fibrosis?
It looks like fibrous
Okay.
tissue.
Be careful, yeah,
Maybe
also with
for
fibrosis, because fibrosis, necrosis, because like any other IHC marker, sometimes you will have a sea of staining in those areas. Sometimes. I know you're looking for
I'm
your.
looking for my. So, you know, like everything in life, the way you practice continues to evolve. And I don't know how old are these cases that we selected.
A little bit, I think.
And I know that more recently, let's say in the past 2 or 3 years, we got wizened to the fact that if you don't fix the appendix, it looks fixed. Don't worry about it. Just fix it more. If you don't fix it before processing, you don't get the same analytical performance.
And I think it's the same also with the tonsils that we are using for PD-L1 and other controls.
But I think this is kind of.
It's not terrible.
Not terrible.
I think it's like acceptable how they're calling it. Not great, but acceptable.
Okay. And this is our core biopsy. Again, it looks very negative. And there's a little blush. Okay, so this is
These
the muscle.
are the muscles, yeah.
And more muscle here. And then some pigment. And then
I think this case
really.
didn't cause any issues.
Yeah. Okay. Fantastic.
And it's also reflected in the
so we
in the percentages.
We go to try. Let's see. Oh, this was sorry.
This was 1.
So this is the 3rd one.
Okay, another indeterminate, but we don't know.
Okay, so this one is kind of mostly positive or just a question mark.
Negative. Someone said a negative. So someone said indeterminate reflex orthogonal, so probably was still right with the diagnosis. I mean,
yeah, eventually you probably would. Although you could get a negative-ish.
Well, yes. Hopefully.
Okay, here a bit of necrosis, viable tumor cells. I think again these are not so difficult to identify under the microscope. See, these are all crash artifacts. And so you will need to worry about interpretation eventually. Again, you see this is low power diagnosis. It is, but then make sure this is not mucus or
necrosis, because you did have necrosis over there.
Okay, this is another type of appendix. Oh, this is so much better, you see already. This is next generation. And you see how now you see staining in the mucosa. And how do I know this is non-specific? I have no idea. But I think these
they are,
specific.
They are genuine.
These dots are, I think they are specific.
Exactly.
I think if you stain for S100, you find the same dots. So maybe they are general. Maybe we should stain for neurofilaments. I don't know. Anyways, okay, good. So this thing here, there is a bit that is not staining. Oh, heterogeneous, like Emilia says. Well, if you ask me, I would say if this was all we had, I would say indeterminate.
Definitely.
Yeah, because there is something, but I'm not so sure. Definitely. I want to treat on this basis.
And especially when you don't have that strong staining, cytoplasmic staining, like this one that we're seeing now.
So this is nice. And then remember that there are necrotic areas. If you cannot, okay, this is quite obvious, the necrotic area, but look at the H&E again, because theoretically, this could be the necrotic area, picking up the stains, and this could be the better processed tumor not picking up the stain. But this is really good because you have this negative nuclei, and so the pattern is good.
Now question, exactly like you said, let's inverse this. If the necrotic area would have been tumor cells there, how would you call that staining? Because it is some staining over there. Weak,
if you have viable tumor cells.
Viable tumor cells.
Non-staining.
Yeah, viable tumor cells, but exactly staining with that intensity. So you have some granular.
Yeah.
A little
this
bit.
Intensity,
This
yeah.
intensity.
This is non-specific.
So you would call it negative?
Yeah, I would call it negative.
And if you had a little bit more?
You know, this is
because look here, it's not.
Yeah.
It is a little bit more.
Simona,
Would you call it indeterminate in the end?
This is the problem. The problem is that at the end of this biopsy, there will be a patient
Exactly
who is told, "Oh, ALK negative. What if we are wrong? What if there was an issue with this booming biopsy?" And actually, he's got translocation. It could benefit. So possibly everybody
Those
would
cases,
probably
indeed,
chase it.
I think I found them the most difficult, where you have this almost diffuse cytoplasmic staining, but not strong, weak to maybe focally moderate. Those I'm really struggling with them. And probably, usually I'm a little bit reporting them as indeterminate, and I'm reflexing.
Yeah, reflex. And then, you know, because the problem with each break apart issue is if there is an inversion or a translocation very, very close to the ALK, the break apart doesn't show break apart. It still show the signals very close together.
Yes.
So maybe we should actually maybe move forward and say when the immune is indeterminate, we should do a sequencing job, you know, or something different.
Yes, but that's also about accessibility. I mean, to have an access to this kind of tools.
Sure. Okay.
But I would really also advocate for that, because the false negative rate in fish is quite high if you compare to both NGS and IHC.
Well, I know, but when you say high, we are still single digits.
No, I think I'm looking at a paper, it's from 2019, and they have like more than 30% that.
Okay, but that's probably something I've done in my shed at the weekend. So at these credible people, 30% is very high. It's too high.
It is high.
Yeah, that's not, I think.
But that you don't see that with IHC and NGS. NGS, you pick up almost everything.
Yeah, but most serious, where there are these comparison, the discrepancy is a few percentages, you know, 5, 7, not 30. 30 is huge. 30 is, I think these people don't know what they're doing. No, sorry, but I don't know. It kind of is a bit high. Yeah, but anyway, but Emilia, what do you think of this one? This area of the tumor, which looks,
that area is very tricky, but it's kind of, I mean, you have the granular cytoplasmic, but just not so much of it.
Yeah,
I would have called this indeterminate.
Indeterminate, and you see some of the tumor is completely negative.
Yeah. So
this could be a heterogeneous job. And by the way, this one, I wouldn't trust this one very much. This doesn't look right to me. And it's too weak. ALK needs to be strong or at most moderate.
I want to have it strong. But I also think, coming back to your comment previous, Simona, when you have a lot of necrosis, and I prefer even to see if there is another sample available, because if the sample is poor or the pre-analytics are poor, you can't do magic with any technology.
Yeah, that's true.
You see, this is the H&E. It's not brilliantly preserved, isn't it?
But that's over there.
There's a lot of
necrosis,
so it's kind of bordering on hypoxia here. Okay. Interesting, nice case. Now we go for the amazing ROS.
Amazing. Look, we have a little bit more speed here.
Yes, more controversy and reflex. And also the expert group thought, call it positive. So remember, when we have IHC positive ALK, we say IHC positive, that's treatable. When we have IHC positive ROS or even NTRK, you really need to show that there is a translocation. Yeah. Yes. Okay, so.
Yep. Perfect.
Oh, they're all core biopsies. That's very generous.
Beautiful.
Nothing is happening.
We can talk. Pitfalls in ROS, pneumocytes.
Ooh, pneumocytes. Maybe that's where TTF1 is useful. No, because TTF1 stain both.
Exactly, no.
Yeah, so I don't know.
Me neither. We'll see.
It's old-fashioned histopathology.
And again, pitfall for ROS is for me, the threshold of 30. What are you doing if you have 20 or 25? I'm calling it negative.
Reflex. You reflex anything.
It's a robust diagnosis of
Well,
the threshold 30,
okay, so,
you know.
yeah, okay, so the 30% was the lowest amount of positive cells that ensure you don't miss translocated cases. Yeah. That's in a study,
Yes.
you know, but that doesn't mean in your sample is also 30%, is it? Because nobody has done a study in your sample. They've done a study in their samples.
Now, I don't think if we have a few cells, now we are going to reflex, but I do think if it's not fully positive, then a matter of positive or negative, even in these cases that we scored, it is a little bit, it is reaching the threshold of 30% or not. And I'm pretty sure people that score them negative, and if we have staining, it is a matter of percentage in the end.
Yes, and also you probably want to also put in the context, the clinical context, the age of patient, smoking history. All
and again, if you've done the whole panel for lung, if you also have ROS and TRAC, EGFR and everything, and you have a mutation, then it's less likely false or ROS, I guess.
Because they usually say this is kind of one mutation will do,
one hit.
You don't have another hit.
Yeah.
Although some tumors have more than one hit and then they don't respond to that treatment because they have alternative pathways anyway. So this is ROS controls. These are, don't know what they are. They look like cell lines, but it could be an ascites. A cytospin.
This looks like a cytospin a little bit.
I don't know what we use for ROS.
Now you are using cell lines and I'm using one positive, one negative one.
This may be
so I think it's a little bit more older case that we had. Yeah.
So obviously there will be some mesothelial cells and some inflammatory cells, and then your little balls of adenocarcinoma. And it's quite nice. Diffuse positivity, but it could also be membrane. Cytoplasm, it could also be membrane. And again, look for that negatively stained nucleus, because the dogma say that if you find positive stained nucleus, like, I don't know, this thing, maybe it's a dead cell rather than a real, things to assess. Okay, so here is another one, and here, not so sure. Okay, so that's the control, and this is our test. Okay, now that's interesting. What do you think? I can tell you what I think immediately. This is a spot diagnosis. Tell me, speak to me.
I'm trying, but
these are lining.
Exactly. I mean, I'm looking.
These are the residual.
Yes, more in the other area. This is
you see, this is the tumor cells, and
your
this
cancer.
This is beautifully
the
pneumocyte reactive. Okay, let's see if we can find them. I may be wrong. So is this one here probably?
It might be flipped, Look, this shoulder is there. Yeah.
So maybe here and to this side. These ones?
No.
No? Okay, just a moment. I haven't really done this properly.
No.
No?
Yeah, you've done it. Okay, I think.
I lost this.
Zoom out, that's it.
Okay.
Yeah,
there. Can I synchronize? I need to put at the right 2.7. 2.7. Okay, synchronize.
More or less.
So
you know what, it induced me in error. What's inside? Because inside I could see these are like tumor cells.
They are side by side. This is, you're never going to find it, but there are smaller cells here.
There are smaller cells, exactly, and that's, you can see, because inside you can see those are proliferating.
Yeah, it's more the pattern. To me, it's more this pattern is more telling you these are resident.
Okay.
So resident or not resident, what do you call this? Positive or negative? Element of doubt?
Element of doubt, yeah. Well, these, for example, These, I think, they are tumor cells.
Could be 30%.
These again, they are tumor
Strong or
cells.
moderate intensity.
This is tumor again.
This is tumor.
So taken all together,
We
overall,
say
reflex.
positive reflex. Yeah, that's what we say.
I think it's just too much. And it's too much compared with the tumor, with the H&E.
What did we say? Positive reflex. Okay, all right.
But
positive reflex.
it was
And
quite a majority that say 36% they
Yeah.
said negative. And I can see, because if they are taking into consideration, they are scoring those being only reactive pneumocytes, but I think it's just too much to be just reactive pneumocytes.
maybe not. Anyway, but fish is.
There is also a comment here,
Yeah.
if the point really is 30% threshold,
Yep.
then why is this positive? Does it really reach 30%?
That was my I did make some comment, probably not. And remember, it's 30% moderate or strong intensity, so you should
weak.
not take the weak ones. So probably not. But again, you know, Emilia, when there is a patient, what do you do?
No, and I actually, the study that I think you referred to, the Rosing study, I think one of their statement really stuck with me, that this presented is at the tolerance of the pathologists, what he said for sensitivity. It's really what can you tolerate, because you might miss some cases if you increase it or if you're too strong on 30%.
Exactly.
You know, the same kind of consideration apply when we threshold ourselves for the 2+ immunohistochemistry on HER2. And I know that a lot of colleagues kind of tolerate less, and they kind of say, oh, I don't care, let's do an ish. Yeah, you're right. It's about our personal choices. And also, you know, what I told Simona is that while it's great in the study, wherever it was, that they find 30% is the threshold, you really don't know what happened in sample of the British population, you know, in your institution, because nobody has done that. So take that with a pinch of salt, I would say. Okay.
I think your other comment on really looking at the complete picture, the panel, other findings, and making a decision for each and every patient there.
Yeah.
Definitely.
But you know, also, Simona, I mean, you know, we are laboring over these things, and now a lot of some centers, they just do sequencing for everything, and they do large scale sequencing. And so these kind of exercises become less important, I guess. Although, you know, in some centers, patients don't have access to NGS. So, you know, you need to do this way. I don't know, because obviously, even if you can demonstrate a ROS1 mutation, only 75% of patients respond well. So there are still escapees. And maybe there are escapees because we don't look for another hit. And the patients have another hit, which makes them escape. I don't know. Yeah. Okay.
But I do find with ROS a little bit, it's not that encouraging, especially even when you see, and we had cases, positive, strong positive, diffuse strong positive, we reflex it to fish, and then they came back negative.
But you know, in retrospect, I wonder whether we should really start doing sequencing, not fish.
Yes.
Because I'm not so sure I am
With
100% at one with this fish. I don't know. Yeah. Okay. Okay, so fifth case, we're
even more split here. Negative 52.
50-50. And sorry, it's a negative, and then
Fish was negative.
Fish was negative. So
this cytology.
Nice cytology. Yeah. Don't know what these things
are. And regarding also the comment with the cytokeratin or even TTF1 or something. Yes, I think these ones, and especially when you need, and I found it quite useful sometimes also with PD-L1, when you need thresholds of percentages, how many, so it gives you an overlook on how many tumor cells you really have in that biopsy, so you know what you're searching for. So that, in this kind of cases, it is
okay. So this is a newer case. We are using cell lines here. And it's a negative cell line, a cell line with I don't know what, some very
Should have
weak
been
expression.
intermediate, I think, or something.
And a cell line with more expression. Okay. And that's our case. There are occasional cells with cytoplasmic staining. Are they tumor cells?
Well, let's assume they are. They are bigger.
I quite like this TTF1 concept. Maybe we should use it.
Yeah.
How do you know what these things are? Could be macrophages.
You know, side by side. Oh, yeah.
You will never find them side by side with the HNE. And even on HNE, you know.
But look, there are way much more.
This is a doublet. This could be mesothelial cells.
Some of them, they are pleomorphic. They look a little bit.
Okay, so this case is in our slide tray. What do we say? Positive or negative?
Not convincing. This would be one of the cases that I would call indeterminate.
You would call it indeterminate.
I wouldn't call it positive.
So basically, any staining whatsoever, you reflect.
That kind of cases, because you gave also the example with the HER2, when I'm not calling it, I want to perform dish or fish, but I don't want to call it 2+, because it's not a 2+.
Yes.
And I have different reasons why I want to do a dish.
True.
And I'm calling it indeterminate.
Yeah, call it indeterminate. Don't say positive. Because also, if you say positive, you are telling the clinician there is a lot of protein. Actually, there isn't a lot of protein.
No, and it's moderate.
Yeah.
I don't know if it's strong necessarily, maybe very occasional, but you have quite, if all this staining would be indeed, like you said, tumor cells.
I suspect these are not tumor cells.
Well, fish was negative in the end, so.
Okay, all right, so fish negative. I don't know if anybody has any bright ideas apart from the double staining. That's a good suggestion.
Yeah.
Probably this would be negative. I don't know also, if you do fish in house, also, like 2 days later, a day later, you get the result. Probably there's not a lot of delay. Would you delay an MDT decision because of this staining? I would probably say not really. I think this is negative.
Okay, I understand your point of view, but then are you 100% that this is negative? And then you are saying, you are telling them, no, it's negative, and maybe the patient doesn't have any other mutation. And then in 2 weeks' time, your fish comes back being positive, and then what?
Okay, but
I mean, if you're 100%, it's fine.
Okay, but maybe you should tell the MDT, there is some staining. I think it's not in the right place. For completeness, I'm waiting for the issue, but I would go ahead, start planning for your alternative treatment, whatever the alternative treatment is.
I think that's the best approach.
Yeah. Because otherwise we skip 2 MDTs before we decide what to do. That's the problem.
Yes.
Okay, good. Any comments?
Yeah, what percentage would you give to this case?
Less than 30, I think.
Yeah, 5%.
5 necessarily.
But they are weak.
They are weak. That's the problem.
Maybe not even 5.
Yeah. But then
you're not really applying the 30% rule.
Well, that's the thing. Yes, you can see how our reasoning start to move out of the 30% rule because we are in diagnostic settings now. Yeah. So of all these cells, I would, to me, moderate qualify this one, this one, this one, this one, and maybe this one. So you see the percentage is low. And obviously there are lots of areas with much less staining.
And then you need to take into consideration also the whole background of the patient and everything, especially if you have a young, middle-aged patient. Like, I don't know, would you be happy just to call it negative and move on?
So the expert said positive reflex, eh?
I don't know.
Okay. I think what we should do is, if you say positive,
I'm not saying positive, yeah.
If you say you reflex, and then it's not no mutation, it comes out of your salary.
Yes, that's
true. Is that
true.
all right?
Yeah, that's not good though. But what if it's positive?
Then you double the pay. Yeah.
Good.
Okay. All right. So last case. This one was possibly more obviously positive from this data on immunohistochemistry, and again, disappointingly negative on fish. Last case. I don't know. This is the HNE. Yes. Oh, general score. Again, these are well-differentiated tumors, so could be not so well-differentiated, a bit ugly looking.
And also
these are the cell lines. These are the cores. Oh my gosh. I think it's negative.
I was just about to say.
Can you be positive? Because there is this veil.
I don't think we call it positive on the veil.
Would you?
I don't think so.
Let's see, they may be better. This is more tricky.
Come on. No, I cannot believe it. Ah.
Uh-huh. Okay. Okay.
I was literally like, come on, it cannot be just that one.
Okay.
But again, you also have the same issue, moderate and strong intensity. You have quite a lot of weak.
True.
Do you have 30%?
This would be, for me, this would be, I see positive with low expectations.
With low expectations.
Do you grade your diagnosis with high expectation and low expectation?
You know what's the problem, especially in DMDT, the other pathologists will understand what you're saying.
The oncologist?
Maybe, but the rest, the surgeon definitely not.
But they already think we're stupid. It doesn't matter.
Well, my point being is that they will not do anything until you say very clear, positive or negative, and you take it upon you.
True. At the end, what it is, please stop faffing around.
Yeah, exactly.
Positive or negative.
And it's the same again. We are going back with the DDISH. ER positive, PR positive, HER2, 2+ DDISH awaits. Okay, so we are postponing. No, you don't need to postpone. She's 80-something years old. She's not going to receive Herceptin, so let's move on. No, because we don't know the HER2 status.
Okay, yeah.
So it's going to be the same. We don't know the ROS status. So with low expectations.
I think, the great thing about immunohistochemistry is that you can give an answer straight away. That's the great thing.
Yes.
And I think we need to have the reflex
that gives the same.
Quicker, much quicker.
Well,
so, we were playing with the IDILA machine. Yeah, I don't know if
IDILA.
did we put this through the IDILA? No, but I think the IDILA, the same day you have an answer. So you can go to MDT to say, I put it through the IDILA. There is no evidence of translocation. Yeah. Okay, well, that's this is all from us actually, because we finished.
Yeah, there weren't that. I mean,
some things.
Super tricky.
Yeah, I think we discussed the staining intensity, and in future cytokeratin. Yes, or cytokeratin. Yes, slide. CTF1 would be better probably. I don't know, maybe.
Another issue is as well, us being a referral laboratory sometimes with certain cases, we are receiving only slides, a few slides, not many. So we need to be a little bit careful when we're receiving 3 slides for the test. So you have an H&E, you have the ALK or the ROS, depends what they are asking for, or maybe both, and then you have 4 slides, and then a spare. So first you're waiting to see if your test worked,
and then
not repeat it, and then maybe you have 1 spare that you can do additional tests.
But I have to say, if any of you in the audience have this as a flow referral, I think you really need to talk to the laboratories that send your stuff and say, look, listen, to enable for me to give you good service, you cannot just give me 2 slides and hope for the best.
I know.
You need to have different arrangements.
We do have, and we do have with the majority, I would like to say, they're sending the block, but depends.
Very good. Okay, so ahead of time, unusually for us, we can hand back to Emilia, or actually just to hear comments as well.
Yeah, no, I do have a few comments because I think ROS is a struggle, indeed, but just because of we can have this protein expression and not being able to detect anything on fish or even on NGS. On the other hand, I really would like to point out that ROS break apart fish. I mean, we have a lot of different fusion partners, right? And the break apart will detect the most common break apart site, but not if there is an uncommon break apart site. So I think we generally talk about fish as an assay, but we need to know exactly what we're looking at there as well. And my preference for ROS is really NGS. With ALK on the other side, I really do think that IHC and protein expression gives a lot of information that NGS is for me equally good for ALK, but there's also this, you know, genus where you might miss clonalities of ALK.
Yeah, but you know, maybe this is not a discussion for people that work at the MD Anderson or in Cambridge or something like this, but maybe from people like you and me that have limited resources. I would say I would not go to NGS immediately. Why don't you do a PCR to show if there is a allelic imbalance? Because if there is a allelic imbalance, then yes, go ahead and do some sequencing. But if there is no allelic imbalance, what's the point?
No, you're right. Yeah.
This is when you read them from both sides, and obviously, if one is translocated, you only have one signal, and the other one doesn't really compute. Yeah. So this kind of a way of handling the
and going around with the tricky.
Yeah.
Yeah, I'm not a huge fan of the type of sequencing we do at the moment. Actually, since you are here and since Roche is now has launched this new amazing sequencer, I will start agreeing with you that maybe the new sequencer, this is, I mean, nobody, maybe you guys don't know, but Roche has now launched a months ago or so, this sequencing by reading by pore. It goes through the pore and it reads something ridiculous like 600 base pair per second or something like this. And is very accurate and is relatively easy to do, and it doesn't worry about formalin fixed material. So that's a different ballpark, you know, but the sequencing that we are used to by next generation, which inevitably is a consequence of how many tumor cells you put in, how many normal cells you put in, all these type of things. What is the, how bad, how good is the material? I'm not really that great a fan of this matter. And in any case, you know, there is a lot of computation, a lot of data analysis when you read the DNA. It would be much easier to do by cDNA. So you take a RNA, so the transcript is the fused transcript, and then you read that. But a lot of, well, the Illumina sequences they do from DNA. So again, there is a huge amount of computational assumptions to tell you whether there is a mutation or not in this, there is a translocation or not. I don't know. The problem is that we super scrutinize the poor idiots that read the immunohistochemistry and tell them with EQA that your analytical performance is poor and your whatever it is. But how do we scrutinize the people that do sequencing? Nobody goes there and say, well, we think that your percentage of response in your mutated tumors is low, because we don't even collect the data. So I don't know. Anyway.
Somewhere.
And do you want to comment on the molecular EQA?
Now there is also a molecular EQA where they look at all the parameters and even the way they do the report, because all the European EQA are aligning on applying the same strict let's say characteristic to say if somebody pass or don't pass. So, but the truth is, like, it's not mandatory to participate to an EQA. It's good practice. If you are ISO certified, you do it. So what I don't know is how many molecular lab participate to do EQA. But there is, for sure, for molecular, there is even more steps compared to...
Yeah, but I'm sure they all do, but they don't do EQA on patient samples. They send you the samples that are quite clear cut, whether there is mutation or not. And it's not the same as your paraffin embedded tissue that you try and read. And also, they tell you you're okay 3 times a year. Well, what about tomorrow?
Yeah, but please.
Well, I don't know.
You cannot have them have it all.
Sure. You can see that I'm not a fan.
Yeah, I can see. I think everyone
Of
could see.
sequencing. Okay, right.
Well, I'm not the sequencing expert, but I do believe there are a lot of qualitative assessment as well, that you know that you have the DNA quality and the quantity before you even put it for analysis. So there are certain steps, of course.
Yeah.
But I also think we just at the beginning, it's not everyone that can manage a full sequencing system with the informatics that is required. So hopefully that will be much better now soon.